I am going to introduce our first speaker who's going to talk about something of substance, and that's Hafiz Abdul Aziz. Hafiz is an excellent pharmacist, originally trained in Malaysia and did his PhD with us here at University of Queensland, returned here to do a postdoctoral fellowship and is an NHMRC Emerging Leadership Fellow. He has been very strong in the area of understanding what the value is of changing the infusion duration of antimicrobials in patients with sepsis as a way to improve the achievement of effective concentrations and then to measure what effect that has on patient outcomes. And so that's what he's going to be talking to us about in the BLING program, where BLING stands for beta-lactam infusion group. Hafiz.
Thank you, Jason. So the topic of my presentation today is prolonged infusions of beta-lactam antibiotics in sepsis, BLING-3 and BLING-3 PKPD. So BLING stands for beta-lactam infusion group. So sepsis-related mortality is high worldwide, and here at the AMO group at Fraser Institute, we have investigated various ways to optimize antimicrobial dosing specifically for this patient population. And such an approach includes exploiting beta-lactam antibiotic pharmacodynamics for maximal bacterial killing. So for the beta-lactam antibiotics, as the efficacy of these drugs depend on the time of the drug spent above the MIC or the minimum inhibitory concentration, there is a biological rationale for prolonged infusion, which can be extended infusion or continuous infusion to be better than the standard intermittent infusion to achieve optimal exposure for bacterial killing. However, whether this PK and PD benefits translate into clinical outcomes remains uncertain before we completed BLING-3. So therefore, under the leadership of Professor Jeffrey Lipman, Dr. Joel Delahanty, and Professor Jason Roberts, our group undertook a stepwise research program to determine whether prolonged infusion of beta-lactam antibiotics improve clinically important outcomes in critically ill patients with sepsis. So to be fair, as you can see from the slide, a lot of background work has been performed prior to BLING-3, and it is really difficult to summarize them in one presentation, particularly the work of one Professor Jeffrey Lipman. So when we were presenting the results of BLING-3 trial, there was a guy who tweeted on X or Twitter. So the guy running BLING-3 has been investigating this topic in one way or another since before I was born. Astounding dedication. That's Professor Jeffrey Lipman. I think he's online now. So the BLING-3 started with the BLING trial. So the aim of BLING trial was to it's a proof of concept trial where we want to demonstrate the feasibility of randomizing patients into the two groups, continuous infusion or intermittent infusion. So BLING-1 was a multi-center, double-blind, double-dummy trial comparing continuous versus intermittent infusions of beta-lactam antibiotics in 5 ICUs across Australia and Hong Kong. So we recruited 60 patients in BLING-1. So in BLING-1, double dummy design was used where patients receive both an active treatment and placebo control. So in BLING-1, we have already observed some signal. We found significant pharmacokinetic separation in terms of the time above MIC. And we saw higher clinical cure rates favoring continuous infusion, but no difference in mortality was observed. And then we proceed with the BLING-2 trial. So the BLING-2 trial was a multi-center, double-blind, double-dummy phase 2 trial, which was performed in 25 ICUs across Australia, Hong Kong, and New Zealand. we recruited 432 patients with severe sepsis commenced on one of the above beta-lactam antibiotics, either piptaz, meropenem, or ticarcillin clavulinate. So, although survival was not significantly different between the two treatment arms, as you can see on the slide, there was already a 1.8% to 4.4% reduction in absolute mortality measured at ICU discharge, hospital discharge, and day 90 mortality favoring continuous infusion. So subsequent to BLING-1 and BLING-2, and we also have a study, the BLISS trial, which was performed in Malaysia. We performed an individual patient data analysis combining these trials, and we found a decrease of hospital mortality at day 30, favoring the continuous infusion arm. So given these consistent clinical findings favoring continuous infusion, there was a sufficient justification to conduct a larger phase 3 trial to determine if there is a survival benefit associated with continuous beta-lactam infusions. So we then use all these data to calculate the sample size, and we found 7,000 patients for the BLING-3 trial. So then we proceed with the BLING-3 trial. So BLING-3 was an international open-label phase 3 RCT conducted across 104 ICUs across Australia, Belgium, France, Malaysia, New Zealand, United Kingdom, and Sweden. So we received a 6-month extension of recruitment for the BLING PKPD arm. So BLING-3 essentially compared continuous versus intermittent infusions of equivalent 24-hour dosing of meropenem and piptaz, and the primary outcome was all-cause day 90 mortality. And we also investigated secondary outcomes, which included clinical cure and resistance development, and also some of the tertiary outcomes listed on the slide. So for this one, more than 29,000 of patients were screened across the 7 countries, and 7,200 patients were randomized to receive either continuous or intermittent infusion of meropenem or piptaz. 7,031 patients were included in the primary analysis, and 6,950 were included in the safety analysis. So the baseline characteristics were balanced between the two treatment arms. 41% of patients were culture-positive infections, and 96% were gram-negative infections. So the outcomes. For all-cause 90-day mortality, there was a 1.9% of absolute difference in mortality favoring continuous infusion, although this was not statistically significant. But we have a pre-specified adjusted analysis where we control for sex, Apache 2 score, source of admission, and study drugs. There was a 2.2 absolute difference in mortality favoring continuous infusion, and this was statistically significant. Clinical cure was also statistically significant favoring continuous infusion arm. So no statistically significant difference was observed across any of the tertiary outcomes, as you can see on the slide. And there was also no subgroup differences observed in BLING-3. As you can see, in terms of pulmonary infection, beta-lactam antibiotics, age, sex, and Apache 2 score. So to provide an updated summary of current evidence in light of the BLING-3 trial, we proceed to perform the systematic review and Bayesian meta-analysis to assess to identify whether prolonged infusions were associated with reduced all-cause day 90 mortality in critically ill adults with sepsis or septic shock. So secondary outcomes included clinical cure and ICU mortality, and we identified 18 RCTs. but 17 RCTs with 9,014 patients contributed data to the primary outcome, which is all-cause 90-day mortality. So these were the studies that were included. So in our analysis, the use of prolonged infusion was associated with lower 90-day mortality, and based on Bayesian meta-analysis, there was a 99.1% of posterior probability that 90-day mortality is lower for prolonged infusions when compared with standard intermittent infusions. Prolonged infusions were also associated with an increase in clinical cure and lower ICU mortality. So that's the BLING-3 trial. So based on the BLING-3 trial and also the systematic review and meta-analysis findings, this evidence presents a high degree of certainty for clinicians to finally consider prolonged infusions as a standard of care in the management of patients with sepsis and septic shock in the ICU. The number needed to treat based on the SRMA was 26 patients. So we also have the BLING-3 PK/PD sub-study arm, where we aim to investigate the association between the exposure of beta-lactam antibiotics, peptides and meropenem with patient outcomes. So we receive FDA funding for the BLING-3 PK/PD sub-study. We also had NHMRC and Royal Brisbane Foundation funding for BLING PK/PD sub-study. So again, we aim to describe or investigate the relationship between beta-lactam exposures with patient with sepsis, with patient outcomes, which included day 90 mortality, clinical cure, and resistance emergence. So we collected 3 blood samples for antibiotic concentrations, and samples were collected between day 2 and day 5 of therapy. This is the PK component. This is our sampling scheme or sampling strategy. For continuous infusion, we collected 3 blood samples 4 hours apart. For patients receiving continuous intermittent infusion, we collected semen, C50% or the mid-interval concentration, and 30 minutes after the infusion was started. We also had the PD component, where we brought all the isolates to UQ-CCR, and we measure the MIC for these pathogens. So the approach is to link the concentration that we identified in these patients and link with the MIC to see whether there are any exposure that can be linked with any of the patient outcomes. So the preliminary findings, we included 182 patients, 119 patients receiving piperacillin-tazobactam, and 63 patients receiving meropenem with confirmed gram-negative infections. Mostly were Enterobacterales and Pseudomonas aeruginosa. So we identified a significant relationship or significant association for piperacillin-tazobactam. We identified the free semen or free steady-state concentration over the clinical breakpoint of between 1 to 4. So this was significantly associated with clinical cure at day 14. So the conclusion that we can have from this BLING-3 PK/PD, in patients with gram-negative sepsis treated with peptides, we should be targeting a free minimum concentration or steady-state concentration of 8 to 32 for Enterobacterales, or 16 to 64 for Pseudomonas aeruginosa. So we didn't find any significant association for meropenem. So this just highlights the complexity of conducting BLING-3 and BLING-3 PK/PD. So I would like to, on behalf of the BLING committee member, or I would like to thank all those who were involved, especially the study monitors and study coordinators. I have had the opportunity to be working on the BLING-3 trial monitoring committee, and I don't envy any of the clinical trial monitors, because it was really hard performing trial monitoring for 7,202 patient clinical trial. These are the BLING-3 trial sites. And I would like to also thank and acknowledge our funding organizations. Without them, I would not be, the BLING-3 and BLING-3 PKPD would not have been feasible to be completed. Thank you very much.
Thanks, Hafiz. I think we might have some questions at the end if anyone really wants any. But that's a really good example of a pharmacokinetic program underpinning the need and justifying a clinical trial, and within which that clinical trial we performed a PK/PD sub-study to further explore how we could continue to optimize therapy, and which has then led into another clinical trial which we're not presenting on, but which we have currently running at the moment.